Welcome to another lecture on my YouTube channel, Rounds in the Fast Lane, the channel which I created to help interns, residents, and medical students to deal with the most common topics in practical medicine. Just like my other lectures, I'll be uploading these notes in the link in the description box below. So today's lecture is on the overview of management of dual antiplatelet therapy and anticoagulation. I'll be briefly going over a few tips and important points about using these medications, and the detailed discussion about each topic is what I'll be doing in future. Now, today's lecture is on dual antiplatelet therapy. Dual antiplatelet therapy you'll commonly come across in two settings. In case of ischemic stroke, where the main P2Y12 inhibitor that is used is clopidogrel, and in case of the cardiac issues, where the P2Y12 inhibitors that you will commonly see are clopidogrel, ticagrelor, and prasugrel. Now, in case of ischemic stroke, the only thing that I'll be discussing here is that you have to remember that in case of transient ischemic attack, you will be calculating the ABCD2 scores, and if it is more than equal to 4, or in case of minor ischemic stroke, where the NIH stroke scale is less than equal to 5, DAPT is used for 21 days, followed by single antiplatelet therapy. In case of ischemic stroke due to intracranial large artery atherosclerosis, you will use dual antiplatelet therapy for 90 days, followed by single antiplatelet therapy. I'll do a detailed discussion on the use of antiplatelet in case of ischemic stroke, and how do we manage stroke, both ischemic and hemorrhagic, is what I'll be doing a separate lecture on. For the purpose of this lecture, we'll keep it focused on the cardiac issues. In case of the heart, the dual antiplatelet therapy is mainly used after a stent placement for helping with re-endothelialization of the stent. Now, for how long are you going to give the patient dual antiplatelet therapy? If the stent is placed for acute coronary syndrome, that is in case of NSTEMI or STEMI, you will use dual antiplatelet therapy for at least 12 months. However, if the patient is at high risk of bleeding, you have to use dual antiplatelet therapy for at least 6 months. Now, if the stent is placed in case of stable coronary artery disease, now let's say a patient comes in with stable angina, undergoes a stress test, the stress test is positive, he undergoes a diagnostic cardiac cath, and ends up having a stent. Now, in that case, the dual antiplatelet, the DAPT, has to be given for at least 6 months. If the patient is at high risk of bleeding, then it has to be given for at least 3 months. Now, these guidelines are based on the ACC 2016 update. We haven't had a recent update from ACC since 2016. So these are the guidelines for now. They might change in the upcoming ACC updates. After coronary artery bypass grafting, DAPT has to be continued for at least 12 months. There's a class 1 recommendation for acute coronary syndrome. If the patient undergoes coronary artery bypass grafting, CABG, for acute coronary syndrome, then you have to give it for at least 12 months. In case of stable ischemic, stable coronary artery disease, if the patient undergoes CABG, then 12-month DAPT has to be given, but it is a class 2B recommendation. If the patient undergoes a CABG after the stent is placed, then the guidelines are same that you will do for a stent placement. Now, in some cases, you will see that a patient will be treated only with medical therapy. Now, let's say they cannot undergo an angiogram. They cannot, if the angiogram is done, but they cannot have a stent placed for any reason. And if they can also not have a CABG done, then usually in these kind of patients where we pursue only medical therapy, then we will give them DAPT for usually for 12 months. And if they are at high risk of bleeding, then usually for 6 months. Now, when we say that the patient is at high risk of bleeding, there are certain factors that decide that if the patient is at high risk of bleeding or not. Like, for example, if the patient has had previous major bleeds in the past, advanced age, in the patients who are taking oral anticoagulation, taking steroids, taking NSAIDs, if the patient is diabetic, having CKD, in all these cases, if you think that the patient is at very high risk of bleeding, then you will follow these guidelines and give them DAPT for the duration for high risk of bleeding. Again, for a short summary to remember, in case of acute coronary syndrome, if a stent is placed, that is for in case of NSTEMI or STEMI, you will give DAPT for at least 12 months. In case of high risk of bleeding, for at least 6 months. And if the stent is placed for a stable coronary artery disease, then you will give DAPT for at least 6 months. And in case of high risk of bleeding, for at least 3 months. Now, what do we do after you give DAPT for 12 months? Now, there are two conditions that I'm going to discuss here. That is prolonged DAPT, that is DAPT beyond 12 months, and shortened DAPT, that is DAPT less than 12 months, or de-escalation of DAPT, in which case we change DAPT from a high potency P2Y12 inhibitor to a low potency, like for example, ticagrelor to clopidogrel, or prasugrel to clopidogrel. In case of PCI or in case of cardiac issues, which P2Y12 inhibitor are we going to use amongst the three? That is clopidogrel, ticagrelor, prasugrel, is what I'll be discussing in detail in future lectures on myocardial infarction, PCI, where I'll be discussing evidence that which amongst these three should be the best choice for your patient. But for now, for the purpose of this lecture, we'll only focus on the duration of dual antiplatelet therapy. Now, let's start with dual antiplatelet DAPT for more than 12 months. What is the evidence that we have? Should you continue it or not? Now, in this lecture, I'm going to keep it very brief, and I'm just going to talk in short about two trials, that is the DAPT trial and the Pegasus TIMI 54 trial. The DAPT trial showed that the extended DAPT beyond 12 months for about 18 to 48 months resulted in 0.7% absolute reduction in very late stent thrombosis, a 2% absolute reduction in MI, and a 1.6% absolute reduction in major adverse cardiovascular events, that is MACE, and a 0.9% absolute increase in moderate or severe bleeding. Now, that trial was done for the patients who were on either clopidogrel or prasugrel. They were not done on the patients taking ticagrelor. The Pegasus TIMI 54 trial was done on the patients who were taking ticagrelor. And this trial showed that after a mean of 33 months, DAPT resulted in 1.2% to 1.3% absolute reduction in primary composite endpoint of cardiovascular death, MI, or stroke, and a 1.2% to 1.5% absolute increase in major bleeding. So, will you give prolonged DAPT to every patient? The answer is no. What you could do is calculate their DAPT score. Now, I will not go in details of of how to calculate the DAPT score. You can pick up any online medical calculator and it will help you get the DAPT score, which basically includes age, if the patient is smoking, if they are diabetic, if they have a saphenous vein graft, if they are having CHF with and also an ejection fraction of less than 30%, the stent diameter of less than 3 mm, if they're having a paclitaxel eluting stent, prior PCI or MI. Now, in these cases, the DAPT score, if it is more than equal to 2, you will consider prolonged DAPT in these kind of patients. And if the DAPT score is less than 2, you will not recommend your patients to be on prolonged DAPT beyond 12 months. Then you can just switch them to a single antiplatelet agent. Now, you can consider giving them dual antiplatelet therapy for an additional 36 months. Now, a few points to remember in case of prolonged DAPT beyond 12 months is that you have to keep assessing these patients for their bleeding risk. If a patient turns out to have high bleeding risk, if they have an episode of bleeding, then in these kind of patients, you can consider stopping one of the antiplatelet and just continue them on a single antiplatelet therapy. Also, one important thing to remember is that ticagrelor, the dose has to be reduced from 90 BID to 60 BID, 90 BID for the first 12 months. And if you're considering prolonged DAPT, then in that case, the dose has to be 60 BID. Also, most of the trials and the studies that showed the benefit of prolonged DAPT, you have to remember that the benefit was more in the patients who have a prior history of MI as compared to stable ischemic heart disease. So this is something that you can consider if you want to discuss with the patient, if you want to continue DAPT in them. So if they have the stent placed for an MI and STEMI or STEMI, then definitely a prolonged DAPT will be beneficial in that case if the DAPT score is more than equal to 2. So this is the discussion regarding the DAPT, prolonged DAPT. Now, what's the evidence that we have since the last guideline update? Until now, we have recently had a couple of trials that have shown the benefit of using a shortened DAPT or de-escalation of. Now, coming to the topic of using short-term DAPT, that is DAPT less than 12 months. Let's discuss some of the evidence in short that we have. First is the Global Leaders trial. This is one of the largest trials, and it was done on about 16,000 patients with about 41% of acute coronary syndrome, including NSTEMI and STEMI, and majority of the patients, that is about 60% of the patient, was stable coronary artery disease. Now, in this trial, they compared DAPT with aspirin and ticagrelor for 1 month, followed by ticagrelor for 23 months. And they compared this with DAPT with aspirin and ticagrelor for 12 months, followed by aspirin for the next 12 months. Now, they did not find any statistically significant difference in the composite all-cause mortality from myocardial infarction, and they also did not find any statistically significant difference in the bleeding between the two groups. But there is another good trial, the recent trial that we have, that is the Twilight trial, which was done on about 7,000 patients. And the good thing about this trial was it was done on and the patients included about 64% were acute coronary syndrome, all NSTEMI. It did not include STEMI patients. And it compared DAPT with aspirin and ticagrelor for 3 months, followed by only ticagrelor for 9 months. And they compared this with DAPT with aspirin and ticagrelor for 12 months. Now, in this trial, they found that among the high-risk patients who underwent PCI and completed 3 months of DAPT, ticagrelor monotherapy was associated with a lower lower incidence of clinically relevant bleeding than ticagrelor plus aspirin, with no higher risk of death, myocardial infarction, or stroke. So this is an important finding that we had in this recent trial that was published in 2019. The other trial is the TICO trial, which was done on about 3,000 patients, and all of them were acute coronary syndrome, and including about 36% of the patients with STEMI. This trial compared DAPT with aspirin and ticagrelor for 3 months, followed by ticagrelor for 9 months, and they compared this with DAPT with aspirin and ticagrelor for 12 months. One of the important inclusion criteria for this trial was that they used all the patients that they included received ultra-thin bioresorbable polymer sirolimus eluting stent. They found that among the acute coronary syndrome patient who underwent PCI with this kind of stent, that is the biodegradable polymer sirolimus eluting stent, ticagrelor monotherapy after 3 months of TAPT was superior to the standard therapy of TAPT for 12 months. Ticagrelor monotherapy was effective at preventing net composite ischemic and bleeding events. Whenever we interpret the results of any of these trials, as I've said in my previous lectures, it is very important to know what are the inclusion criteria and the exclusion criteria. But definitely these recent trials have shown that dropping one of the antiplatelet, that is dropping aspirin, and continuing with monotherapy with ticagrelor has shown to be beneficial. When it comes to aspirin and clopidogrel, there are 2 trials that I would like to discuss in short. That is the STOP DAP2 trial, which included about 3,000 patients, and about 38% of these patients were acute coronary syndrome. And they compared DAP with aspirin and clopidogrel for 1 month, followed by clopidogrel for 11 months. And they compared this with DAP with aspirin and clopidogrel for 12 months. Now, this trial showed that among the patients who underwent PCI, 1 month of DAP followed by clopidogrel monotherapy, compared with 12 months of DAP with aspirin and clopidogrel, it resulted in significantly lower rates of cardiovascular and bleeding events, meeting criteria for both non-inferiority and superiority. These findings suggest that a shorter duration of DAP may provide benefit. The other trial is the SMART Choice trial, which included, again, almost 3,000 patients, with 58% of the patients with acute coronary syndrome, and they compared DAPT with aspirin and clopidogrel for 3 months, followed by clopidogrel monotherapy for 9 months, and it was compared with DAPT with aspirin and clopidogrel for 12 months. They found that the experimental group was non-inferior to the control group in terms of all-cause death, myocardial infarction, and stroke. And the bleeding risk was lower in the experimental group when compared to the control group. So in light of this recent evidence that we have, you can argue that if you feel that the patient requires to be on a single antiplatelet therapy after this duration, and if your patient fits in the inclusion criteria of these trials, you can consider switching them to P2Y12 inhibitor monotherapy. One of the important trials that we have is the MASTER DAP trial, which was done on patients at high risk of bleeding. Now, one of the important inclusion criteria in this trial is that all the patients received a biodegradable polymer sirolimus eluting stent. They compared 2 arms, with one of them including DAP for 1 month, followed by single antiplatelet therapy, and the other one with the standard DAP therapy. And they found that 1 month of DAP was non-inferior to continuation of DAP for an additional 2 months in the patients with high risk of bleeding, when it in regards to occurrence of net adverse cardiovascular events, and also the incidence of major or clinically relevant non-major bleeding was lower in case of experimental group. So this is also one of the trials that showed the benefit of short-term DAPT. Now, when it comes to de-escalation of TAPT, there are two studies that I wanted to discuss. The first is the host-reduced ACS trial that was done in South Korea on about 2,300 patients, all of them acute coronary syndrome, and they compared the use of TAPT with aspirin and prasugrel 10 milligram, and they compared this with the experimental group where the dose of prasugrel was reduced to 5 milligram after 1 month, and this DAPT was continued for 12 months with a lower dose of prasugrel, that is the additional 11 months with in the experimental group. They found that in the East Asian patients with acute coronary syndrome, patients receiving PCI, when we de-escalate the DAPT in the experimental group, there was reduction in the bleeding without an increase in ischemia. So this is an important finding. The other one is the topic trial. It was done on a smaller number of patients, about 646 patients, all with acute coronary syndrome. And in this trial, they compared patients who were receiving TAPT with aspirin and either prasugrel or ticagrelor for 1 month, followed by de-escalating it to aspirin and clopidogrel for an additional 11 months. And they compared this with patients who received TAPT with aspirin and prasugrel or ticagrelor for a total of 12 months. And this trial also showed that de-escalating DAPT reduced the incidence of bleeding in the experimental group, and there was no difference in the ischemic events in between the two groups. So overall, the use of short-term DAPT and de-escalation of DAPT has been shown to be beneficial in the recent studies. However, we still haven't had the update in the standardized guidelines. But you can discuss these findings during your rounds, and based on the individual patients, you can consider if you want to de-escalate the DAPT or you want to use short-term DAPT. Now, which amongst the two is better for the patients, that is de-escalating DAPT or using short-term DAPT? Now, there was a meta-analysis that was done on multiple trials, and it came to the conclusion that there was no difference in overall mortality between de-escalating DAPT versus using short-term DAPT. However, high-risk ischemic patients would benefit from de-escalation, and the patients who are at high risk of bleeding would benefit from short-term DAPT. So this is some of the recent evidence when it comes to using DAPT for a timing that is other than what is given in the standardized guidelines. And this is something that you can bring up during the rounds, and based on the individual patients, you can consider either cutting short the DAPT to ticagrelor monotherapy or clopidogrel monotherapy, or de-escalating it if you feel is at high risk of bleeding. So this is all on the duration of TAPT. Now, there are some important tips that I would like to give for oral anticoagulation. In my previous lecture, I discussed use of anticoagulation in detail for atrial fibrillation. For the purpose of this lecture, there are some important points that I want to discuss that are a common point of confusion amongst residents when we are rounding. So I'll be discussing the use of DOACs in AFib and DVT or PE. Now, an important difference between these two is that you do not need to load the patient for atrial fibrillation when it comes to apixaban and rivaroxaban, whereas when it comes to DVT and PE, a loading dose is needed. That is apixaban for 10 milligram twice a day for 7 days, followed by 5 milligram twice a day. And for rivaroxaban, it is 15 milligram twice a day for 21 days, followed by 20 milligram daily. So this is an important difference between atrial fibrillation and DVT or PE that you have to remember, that in case of venous thromboembolism, you have to load the patient, and in case of atrial fibrillation, you do not. Now, the usual dose in case of atrial fibrillation for rivaroxaban is 20 milligram daily, and for apixaban, it's 5 milligram twice a day. But there is certain exception. Now, if the patient meets 2 out of 3 criteria for the out of the following 3, then you need to lower the dose of apixaban to 2.5 milligram twice a day. That is, if the patient's age is more than equal to 80 years, weight is less than equal to 60 kilograms, and creatinine more than equal to 1.5 milligram per DL. In these cases, you have to lower the dose of apixaban to 2.5 milligram BID. For ESRD patients on hemodialysis, 5 milligram BID dose of apixaban can be used, except if the patient is either more than equal to 80 years of age or their weight is less than equal to 60 kilograms. Then you will be lowering the dose of 2.5 milligram BID. When it comes to rivaroxaban, as I said, 20 milligram daily is the usual dose for AFib, unless the creatinine clearance is between 15 to 50. In that case, you will reduce the dose to 15 milligram daily. Whenever you're admitting a patient, you always have to remember that you check their creatinine clearance, and all the medications that you will put them on admission needs to be dosed renally. This includes all the meds, including antibiotics. For rivaroxaban, if the creatinine clearance is less than 15, or in case of ESRD patients on hemodialysis, we do not use rivaroxaban, and you can choose to use apixaban or warfarin. When it comes to venous thromboembolism, that is DVT or PE, the rivaroxaban usual dose is 20 milligram daily, and apixaban usual dose is 5 milligram BID. No dosage adjustment is needed for elevated creatinine in case of venous thromboembolism. This is an important difference and a point of confusion that is common amongst interns, residents, and medical students when we're rounding, is that this 2 out of 3 rule is for atrial fibrillation and not for venous thromboembolism. So for venous thromboembolism, you're going to continue 5 milligram BID dose for all the patients. When it comes to rivaroxaban, the creatinine clearance cutoffs are a little bit different for venous thromboembolism. That is, in case of creatinine clearance of more than equal to 30, you do not need to do any dose adjustment, but less than 30, and ESRD patients on hemodialysis, you will not use rivaroxaban. So the cutoffs are a little bit different in case of venous thromboembolism and in case of atrial fibrillation. Again, one important point that you have to remember is that you will not use DOACs in case of severe hepatic impairment. That is a Child-Pugh score of in a class C. So in that case, you will not use DOACs. When it comes to the use of warfarin, I'm going to do a separate lecture because it's a huge topic, but just a small overview. You will not use DOACs, and warfarin will be preferred in case of the following conditions, which is mechanical heart valve, any mechanical heart valve, aortic or mitral, you're going to use warfarin. In case of rheumatic mitral stenosis with AFib, when it is severe rheumatic mitral stenosis or the mitral valve area of less than equal to 1.5 centimeter squares, in that case, warfarin will be used. In case of certain conditions like surgically implanted bioprosthetic valve in the first 3 to 6 months, I'm going to do a detailed discussion on this in future lectures. And as I said before, in case of CKD and ESRD patients on hemodialysis, as I said before, we either use apixaban or warfarin, but we'll not use rivaroxaban. And then one important place where you'll be using is cost issues. DOACs are expensive as compared to warfarin, and a lot of patients without insurance might not be able to afford DOACs. So in those cases, you have to give warfarin. Coming to the last part is what will you do in the patients who require both dual antiplatelet therapy and oral anticoagulation? What are the guidelines based on the recent evidence that we have? Now, let's take an example of a patient who already is taking oral anticoagulation. Let's say, for example, if the patient has atrial fibrillation, is on either apixaban or rivaroxaban, and he comes in with an acute coronary event and requires a stent, requires PCI and undergoes a stent placement. Now, what would you do? Now, first of all, in these patients for triple therapy, we call it triple therapy, who are requiring DAPT and oral anticoagulation, the preferred P2Y12 inhibitor is clopidogrel. And how would you give these medications? The patient is going to need DAPT for sure right after stent placement for endothelialization. And in these cases, aspirin will be continued for 1 to 4 weeks. If the patient is at is a high ischemic risk patient, in those cases, 4 weeks of aspirin, and after 4 weeks, aspirin will be stopped, and the patient will only be continued for with clopidogrel and the DOAC for total of additional 11 months. That is, at the 12th month, you can consider stopping the P2Y12 inhibitor clopidogrel. 12 months onwards, the patient can only be on DOAC. Again, in some cases, the patients who are at high ischemic risk, some consultants, some cardiologists can consider continuing a P2Y12 inhibitor along with the DOAC for a little longer, but eventually they will only be on DOAC. In the patients who are at high risk of bleeding, we can consider stopping clopidogrel in some patients after 6 months post PCI, and then only keep them on DOAC you can consider using the Has-Bled score in the patient who have a high risk of bleeding. Again, remember, Has-Bled score is the patients who are on anticoagulation. This is not used for the patients who are only on DAPT. So this is again important point of confusion in rounds. So you can evaluate the risk of ischemia and the risk of bleeding, and then decide what to do after the 12-month mark. But these are the usual guidelines, that drop the aspirin after 1 to 4 weeks, and then drop the clopidogrel after 12 months of the PCI, and then the patient will only be on oral anticoagulation. Some of the important tips that I would like to mention over here is that the rivaroxaban dose, if the patient is on triple therapy in AFib, the dose is 15 milligrams daily, not 20 milligrams. So this is something that you must always remember. The other thing is, in case of peripheral vascular disease, nowadays we have new data that is coming up with the use of aspirin and rivaroxaban 2.5 milligram BID, as shown in the COMPASS trial and the Voyager trial. So the COMPASS trial was done in the patients with stable atherosclerotic peripheral vascular disease, and the Voyager trial was done in the patients who received revascularization for the peripheral vascular disease. In COMPASS trial, it was shown that using aspirin and rivaroxaban 2.5 milligram twice a day had better cardiovascular outcomes, but it also had more major bleeding events as compared to those who only received aspirin. Whereas in Voyager trial, the patients who received rivaroxaban 2.5 milligram twice a day along with aspirin, it was associated with significantly lower incidence of composite outcomes of limb ischemia, amputation, MI, ischemic stroke, or death from cardiovascular causes when compared to aspirin alone. The incidence of major bleeding did not differ between the two groups. There was no statistically significant difference in major bleeding. So in the recent times, when you are admitting a patient, you will see a lot of them are on this dose of rivaroxaban 2.5 milligram BID along with aspirin. And if you investigate, you will find that a lot of providers are starting the patients on these regimens. But one important thing that you have to be careful about is that both the trials had the patients who were on DAPT as an exclusion criteria. So if this patient comes in and requires a PCI, remember that the patients with bad peripheral vascular disease are at risk of having acute coronary syndromes, and you will frequently encounter these patients coming in and requiring a stent placement, having a PCI, and started on DAPT. Please remember to stop the rivaroxaban in these patients, because these patients were excluded. Because if you continue aspirin, rivaroxaban 2.5 milligram BID, and then put them on a P2 vital inhibitor, and eventually you'll find that after a few months, there's a chance that patient can come back with bleeding. So this topic is, the reason I chose this topic is because there are a lot of things that are confused in the inpatient setting when you are new in the hospital, and there are particular points that you have to remember while treating the patients with dual antiplatelet and anticoagulation. If the patient is kept on a medication that they do not need to be on, you can see that a lot of times they will come back with bleeding episodes. So if you admit a patient, go through their medication list, see all the antiplatelet and anticoagulants they are on, see if the patient does really need to be on it, and also see if the patient needs to be on something that they are not taking. Evaluate this, discuss this with your attendings and consultants, and adjust their medications accordingly before you discharge the patient, to prevent them from having an ischemic event, or more importantly, to prevent them from coming back with a major bleed. That's it for this lecture. In the end, I would like to say that this lecture is based on my personal understanding and reading of the topics. I would highly recommend that you go ahead and read these topics in detail and discuss it with your attendings and consultants, and do what is the best for your patients. This lecture is not for medical advice for the patients. In the future lectures, I'll be discussing details about each of the conditions. For example, PCI, more details on the dosing of the antiplatelet therapy in different conditions. And if you like my work, please subscribe to my channel and share this with all your friends and colleagues. Thank you so much if you have listened this far.